the Mental Health and Psychiatric Nursing Assessment. The Psychiatric and Mental Health Assessment is also called as the Psychosocial Assessment, wherein it involves the MSE or the Mental Status Examination. This is basically to assess the brain functioning, and this assessment is a tool in order for us to know the brain functioning of our patient. This assessment is geared towards a construction of a picture of a client's current emotional state. So we will be trying to know how he feels together with his mental capacity and as well as the behavioral function of the client. Now, for nurses, it is important in order to establish, for us to establish the baseline data. And we will use that baseline data in order to create a nursing diagnosis, which will be the basis for us to make a plan of care. And this will meet the client's need. Now, but before we do the psychosocial assessment, we must put some consideration with respect to the client's condition, such as will our clients do have the ability to participate, and he must be able to give a feedback before we do that. As well, we must know that he shall be capable of relating his physical health status, the emotional well-being, and his perception of the situation, and he must be able to communicate. Now, this is almost similar to physical assessment that you have done before, although this examination is dedicated towards an emotional state, mental capacity, and behavioral function. There are a lot of similarities, such as we use the nursing process in order to collect, to organize, and analyze the client's health condition. So we will begin the psychosocial assessment by knowing what are the components in psychosocial assessment. The following are the content of the assessment that we will be doing. We will deal into number one, the psychiatric history. Second to that, we will look at the general assessment and the motor behavior of the patient. Third would be the mood and the affect of the patient on how it affects his mind. Next to that would be the thought process and the thought content. And we will proceed to memory and orientation of the patient. And of course, the most important would be the abnormal sensory experiences that the client is having at the moment of the interview. Some other component of the content of assessment will include the judgment and the insight of the patient. Together, self-concept is also an important topic. And roles and relationship would be another important part of the content of assessment. And physiologic, self-care condition. All of the mentioned criteria and areas are the content of assessment that we will do in the process from the beginning to end. In the conduct of psychiatric and mental health assessment, there is a need for what we call the checklist. As you may see, a checklist is a list of the flow of events or the flow or a guide of questions that will help the nurse in the process of conducting the assessment. And if you may look at this assessment checklist, it bears the name of the client, okay, together with the date of the interview, and this is an individualized checklist for every client. In the checklist, you may note that there are general categories such as observation, the mood, the cognition, the perception, the thoughts, the behavior, the insight, and the judgment. These are the content of assessment that we will conduct with the client. This will ensure that the process of assessment is in chronology, concise, and complete. Below its general category, you may see that there are subcategories, such as number one, in observations, you may see that there are appearance, speech, eye contact, motor activity, affect. And right at the right side, there are boxes from which for each and every questions, for each and every observations, you are going to record or document what you just have witnessed according to your clinical judgment. And this will provide ease to the interviewer as he looks into the details of each and every. It will ensure that there will be no details to be missed. And these checklists are being designed according to the institution where you are using it. The psychiatric history. This is the first part of the psychosocial assessment. This can also be described as the psychiatric profile. And in order to do that, here are the guidelines that we have to follow. First, we have to set the environment where the patient will be more comfortable and cooperative in the process. And this is followed by introducing yourself to the client. And together, you have to explain the purpose on why he needs to undergo interview and at the same time, how long will it take? Now, privacy and confidentiality must also be assured and afforded to the client. Not only the client, but as well the patient or the nurse rather should be safe during the process of history taking. And this makes a little difference between history taking of physical assessment and psychiatric history. There is an issue of safety of the nurse because you are dealing here with a different kind of a client. And to get started, an open-ended question is more preferred rather than a closed-ended question, for this will encourage the patient to be to have a better verbalization. The following are socio-demographic details that must be documented, and these socio-demographic details are somehow being called as the demographics. These are what we call the primary data. And these primary data are the variables or the details that is descriptive of the patient, basic information, the social demographic details. And another important component is what we call the CHIP complaints, or they do abbreviate this as CC, the CHIP complaint. This is one of the vital data. That means it serves as the reason for the visit of the patient or an encounter, your encounter with the patient. This gives reason why the patient is being admitted as well. This is a concise statement that must be descriptive of the signs and symptoms, or specifically it will describe the problem or the symptoms of the patient. And what we do here is when the patient starts talking, we record this based on the patient's own words, or what we call the verbatim. For the CHIP complaint will guide the diagnosis, the treatment, and the care of the patient. Next to that would be the history of the present illness, or we call it the HPI. This is the description of a development of illness. And when you record this, it must be chronological and based on the progression as to what would be the first sign and symptoms. Okay, added to that would be what we call the past history. The past history is the total summary of the health status. This is prior to any presenting problem, and this is being also documented. Others would be the medication, which is also important as to the evaluation of the present medication to be given. Next to that would be the family history. This is a record of the health information, not of the patient only, but his relatives And when we look back into that information, we will include 3 generations of the relatives of the patient. It can start from the children that he has at the moment, the brothers, and then we go to the parents and to the grandparents. Knowing the family history of the patient is important in order for us to determine the risk factor that he may have at the moment, the warning signal, and the management that must be implemented with the client. And social history would be that portion of history taking where it addresses familial, occupational, recreational, personal life. These are the aspects that social history will reveal. And usually in psychiatric history, this plays a very important role, especially in habits that the patient is usually doing, such as alcoholism and drug abuse. And finally, we have what we call the review of the system. This is the inventory of the patient body system that will soon identify the signs and symptoms of the patient. Now, in the end, psychiatric history is that very initial part of psychosocial assessment. That if you may look in the picture, there is this healthcare worker that is compiling all of those information that has been gathered with the patient, and this will form part of the health record of the patient as he is being admitted or confined in such an institution. The general appearance and behavior. Let's assign GAAB as its acronym or mnemonics for ease of remembering. In the conduct of psychiatric and mental health assessment, during our first encounter with the client, we may notice some remarkable features, or we should say the nonverbal communication, which will play an important role in the process of our assessment. And we will record these non-verbal gestures as an observation. And the following are some of those. One, the dressing and the grooming of the patient. Number two, the facial expression of the patient. We may look into the patient eye to eye, and the mannerisms are also observable, as well as specifically the posture. Rapport is necessary in order to develop trust while the patient is confiding to us. Consciousness also must be assessed, and the behavior together with physical pictures. And finally, the client's speech. Let's look into the details of these one by one. The client's dressing and grooming is one of the noticeable factor when you are conducting psychiatric and mental health assessment. Down below, you may see a frame of picture with a lady trying to look at whatever dress she shall be wearing for the day. And this is the decision that we make in our lives every day. In our assessment, we will notice that dressing has something to do with the mental functioning of the client. When she dresses, it must be based on appropriateness. It can be said that she must be well dressed in accordance with the season. When it's too hot, you cannot expect that the client is wearing a fur and a feather coat. And when it's too cold, you cannot expect that the client is wearing just a sandal or a cotton clothing. And whatever situation he will be dealing with, he must accustom his dressing according to the situation. And one of the remarkable um, notions that we have to look into the client is that is she wearing a neat and a tidy clothing? And if not, then it must imply something. In most observation in psychiatric nursing, schizophrenic clients can be described by a bizarre clothings as being expressed in the upper left picture. And it is also being um, an assessment findings in psychiatric nursing that in personality development, those who are having a manic behavior or elated or euphoric feelings are opt to wear a very colorful dressings or clothing paired with shoes, paired with lace. And indeed, dressing and grooming is one of the factors that you have to consider when you are making an initial psychiatric evaluation and assessment. Facial expression and the eye contact. In the process of psychiatric and mental evaluation, the facial expression and the eye contact will be the cues for identifying some moods of the client, such as anxiety, pleasure, confidence, blunt, and pleasant condition or mood of the client. There's this saying that your face says it all, and this nonverbal communication can express more than words can say. And let's take a look at a facial expression to be exhibited by the client. It conveys disgust, sadness, contempt, or irritability, and there can be anger, happiness, but there's a fear, and finally, it's surprising. Mannerism shall also be considered as a factor that can be noticed during assessment. These are habitual gesture or way of speaking or behaving. If you may look at the picture or the clip right on top, if you will look at it closely, you might wonder that this is a familiar situation, not only common to you, but to some of your friends or somebody who you know. They are on top. You can see that there is a lady biting his fingers and nails at all times, unnoticeably or unconsciously. At the right um, upper, there is this guy speaking with his hand gestures. Whatever, whenever he opens his lips, his hand goes with it and trying to express also. And right at the left, you may see that somebody is always chewing a gum, and noticeably, even without a gum, he is trying to show this mannerism. And right down below is a feeling of disgust at the guy at below the lady on the upper portion. The three pictures at the bottom are the pictures of tic. A tic is a sudden, repetitive, non-rhythmic motor movement or the vocalization involving the discrete muscle group. This is in any way or it's somehow related to Tourette syndromes. This may bring discomfort, not only to discomfort, but some moment that is embarrassing to the patient. However, these are what they consider as a permanent condition. And whenever you're doing your psychiatric mental health evaluation, you may document this as a part of observable characteristic of a client's description. A posture is another observable characteristic of a client when you are doing your psychiatric mental assessment. And some of the most common here are the posture and the gait. There must be an occasion that you will ask the client to stand up and you will observe keenly as to how do they carry their posture. By the way, there's a difference between posture and a gait. When we say posture, this is a body position while the patient is seated or standing. And the pictures above will indicate an elderly man who's showing different types of a posture. At the left, you have the hemiplegia, the Parkinson's posture, the cerebellar ataxia, the foot drop, and sensory ataxia. Some of these may be related to medical condition. However, this can also be noticeable during your psychiatric mental assessment with the client. Down below are pictures of a gait. A gait is a person's pattern of walking, and most of this can be observable to psychiatric client. And these are the things that you have to document and note when you are doing your psychiatric assessment. Consciousness is another observable characteristic of a client during psychiatric assessment. And this assessment findings or this assessment method has already been discussed in your early years in medical surgical. And we use here the tool called the Glasgow Coma Scale. And this assesses the eyes, the verbal, and the motor. And this will exhibit the level of consciousness of a client. This is just a matter of recall in psychiatric nursing in relation with consciousness. A physical pictures is one of the observable characteristics of a client when you are doing your psychiatric mental health evaluation or assessment. You will just simply note the characteristic of a client with respect to how do they look. The picture above are age group differences of an individual as to how they look. They may be younger, they may be looking older, or in the middle age or the middle adolescent, and this must be documented as physical features. And down below are body physique and habitus, which can be described as either underweight or overweight. And if a client do have a physical deformity, it must be noted and be documented while you are doing your physical or psychiatric mental evaluation. Behavior is another remarkable and noticeable characteristic of a client during psychiatric mental assessment. And these are indicators of a social relationship. Either a client will exhibit or disinhibit, whether the client can be cooperative or non-cooperative during the process of assessment, whether he is preoccupied, is he aggressive, or having just a normal behavior and conduct while doing your psychiatric assessment. Either all of these can be neglected by an interviewer if he is not very keen on the details, and this must not be forgotten when you are considering a thorough, rigorous, and complete psychiatric assessment, the behavior. This time we will focus on the client speech. The interviewer or the nurse examiner must take note and consider the responses of the client based on the client's speech. And we will assess for the quantity, the quality, or any abnormalities with the rate, the tone, the rhythm, and some neologism that the client will create during the conversation. There are notes to consider, and these are the following. One, the coherence. The coherence of the speech is with respect to the unity and purpose or organization of the content or connections of what the client is saying. And this may be likened into a rope that what he said in the beginning must be connected with the next word and another next word that he will be saying. And that is coherence. Next to coherence is what we call the relevance. The relevance is whenever the client will answer the question appropriately. Or we may say if he answers the question appropriately, then his pattern of speech is relevant. But if he may answer inappropriately, then the pattern of his speech would be irrelevant. And that is relevance. Another factor to consider is what we call the tone and the volume of the client's speech or the client's voice. The volume can either be soft Or it may be the opposite, which is very loud. And the same goes with the tone. The tone can either be very high or very low pitch, or it can either be normal, which is being symbolized by a trumpet with a very high tone or high volume, and a cielo which has a very low tone and low volume. So we may assess the client's volume and tone as if it is soft, loud, or normal, or the tone can either be high or low pitch, or normal, or it can either be monotone. Next would be the manner of speech on how the client delivers his responses or answer to the question of the nurse. The client's manner of response can either be excessively formal, or he may be too relaxed, or either that his response can either be inappropriately familiar. Now, when we speak of a client's manner of response in form of speech, it can either be relaxed or in a hurry, which is depicted by the pictures at the left and at the right of a relaxed caricature and a caricature at the right, which is in a hurry, and that pertains to the manner on how the client will speak. And finally, we have what we call the reaction time. The reaction time refers to the time it takes for the client to answer to your question. The longer it takes, then there is an increased reaction time. And the faster he answers your question, there's a decreased reaction time. And normal would be that's the adequate time to answer the question. And these are the factors to consider and to assess when doing psychiatric mental client speech evaluation. Again, the coherence, the relevance, the tone and volume, the manner, and the reaction time. This discussion is about speech impairment, and this is in relation with the psychiatric and mental health assessment being done by the nurse. In the process, the nurse must be able to identify and document all of the findings in relation to speech, such as alogia, aphasia, dysarthria, stuttering, cluttering, or the clutterer scatterer. First, let's talk about alogia. Alogia, aphasia, and dysarthria are common motor speech disorder which may result from an impairment or any head trauma, or it may be due to a tumor. It can either be due to a viral infection or a stroke that may damage the left hemisphere of the brain. In alogia, there is a poverty of speech, and there is a restriction in the amount of speech that is being used. The client, when in the process of interview, may only answer a monosyllabic words. It's as almost close to mute situation of a patient. In dysarthria, there is a motor speech disorder where there is a damage linked to the tongue or the voice box that may slur the word, and the client will be having difficulty in articulation from the word dysarthria. That's difficulty in articulation. Now, compared with aphasia, aphasia is broader in meaning and in definition, and this has already been discussed in neurobiology. However, if we will recall, there are three types of aphasia, namely the Broca's, the Wernicke's, and the global. The type will depend on what structure of the brain has been damaged. If it is a Broca's aphasia, then the Broca's area has been affected, and this is located in the frontal left anterior. And the Wernicke's is at the posterior left lateral side. The brochas may signify that there is a damage in the production of words. You may understand the meaning of whom you are talking to, but you cannot express the words. And in Wernicke's, this is a more severe damage to the speech area of the brain, wherein you cannot perceive the message that is being translated by the person you are talking to, and at the same time you may not be able to respond or answer back. While global aphasia is said to be, it encompasses both the Broca's and the Wernicke's area, and it has a greater damage. That's why from the word itself, the global aphasia. Let's distinguish between stuttering and cluttering. Now, this may be easy to remember for display an opposite meaning. When a person is stuttering, meaning there is a slow, frequent repetition, or the patient is prolonging a sound or the syllable of the word, or stutter, meaning the client cannot immediately release the word. It is being stuttered. There is repetition, if not prolongation, of the sound or syllable. And this is markedly an impaired speech fluency. Now, in contrast, cluttering is the opposite of that, where there is a rapid, jerky spurts of speech. The client is speaking so fast in cluttering, but it is erratic, this rhythmic, and that you cannot decode the message, or you cannot get the message of the client who's speaking on a cluttering basis. That is almost the same with stuttering, where you cannot also decode the meaning, for this is too slow, too repetitive, and too prolonged sound. But when the symptoms of stuttering goes together with cluttering, then we have a condition called clutterer stutterer. And this exhibits both the symptoms of stuttering and cluttering. Again, when the nurse is doing the psychiatric and mental assessment, the client must have a keen listening ability and observation as to the speech impairment that the client may exhibit in the process of assessment. This includes alogia, dysarthria, aphasia, stuttering, cluttering, or the clutterer stutterer. The mood and the affect. These are components of psychiatric mental assessment. Mood and the affects are two separate assessment findings. Mood is said to be subjective, while affect is said to be objective. Now, by looking at the picture below at the left side, a guy is uttering words which depict his mood. And at the right side, the girl is sobbing or crying, which it portrays her affect. Now, having said that the mood is subjective, and as what we have learned from our previous lesson, if it is subjective, then the patient will verbalize his mood. And in fact, this verbalization can be assessed by the nurse by using a rating scale. Wow, that can be similar to a rating scale of pain. And the nurse can even identify that rating as from 1 to 10. While on the other hand, affect encompasses a broad range of feelings. That means an affect can either contain an emotion or the mood. And affect are said to be objective, and that is overt. Meaning, a girl that is crying will simply exhibit an outward or a visible or a more intense emotion. And that is compared to the mood, which the guy at the left side has a less intense of emotion. The mood does not necessarily need contextual stimulus, unlike that of the affect. Now, finally, mood can last longer than emotion. In fact, this mood can last even for hours, up to days. And you may observe that from the people around you. While the affect is said to be short-lived and can manifest only at a spur of the moment. So these are the differences between mood and affect. The mood. Let's take an even more closer look into a different context of explaining mood. Mood is said to be pervasive and enduring emotional state that is subjective. Now in here, mood do exist in what we call a continuum or spectrum. Now in the spectrum, you may notice that the middle of the spectrum is said to be euthymic or a normal mood. And if we go to the extreme left or to the negative side of the spectrum, you may find here depressed or dysphoric mood. And if we go to the right side or extreme right positive side, we may find here elated or euphoric mood. But in between the normal and the negative side or dysphoric, there exists a mood called anhedonia. And from the middle up to the right extreme, elated, we can find in between the normal and elated mood, the labile mood. Now, let's take a look and listen as to how the euthymic mood is being described in a
Yeah,
clip.
losing my job sucks, but I don't know. Maybe it's the opportunity that I needed to sort of get up out of bed and make stuff happen.
Euthymic is described as normal, and this is the typical mood that we do have. That is, we are upbeat and happy at times when we normally express the context of our feelings, our mood. Now, let's pay attention as to how is a depressed or dysphoric mood.
I can't see the point of coming here anymore. I still feel so low all the time.
In a depressed mood or dysphoric, the person is down or having a blue mood. It is said that she has a low energy, irritable, and anxious. Now, in a bipolar disorder, this is a depressive state. Now, let's take a look into the extreme right or elated or euphoric mood.
So I have to tell you about this. We did this amazing, it was like a relaxation exercise in my yoga class, and it was just so helpful.
In an elated or euphoric mood, that means the patient or the client is having an up mood. She feels like she's on top of the world and having a high energy expressing her emotion. And this is a manic state in bipolar disorder. Now, let's pay attention into how is anhedonia being expressed.
Used to be really into soccer, but kind of played on a team and stuff. But I don't really do that anymore. It's a lot of effort.
Anhedonia is described as a lack of interest or withdrawal from a daily routine, a daily pleasurable routine, something that you enjoy most. And this is associated with depression at all times. Let's pay attention as to what is a labile mood.
I was so excited to have the couch. It looks great in the living room. The color is perfect. It blends with the red walls just the way I was hoping it would. And so I'm really excited about it. But, I just thought, I'm not sure now. I'm not sure now if I'm going to be able to pay my electric bill.
Labile mood is an ever-changing mood. This is said to be capricious and unstable. Literally, we can say that labile mood is what we call the mood swings. And this is commonly happening among children. And others are saying it's happening to ladies whenever they are having hormonal changes during their period. And labile mood to a bipolar disorder is a rapid cycling form. And these are the context of mood. APEC. Let's take an even more closer look as to the details of what is an APEC based on a spectrum or a continuum. At the left side of the continuum is a pool or a broad apex, which seems to be normal. And at the right side of the continuum is a blunted flat apex. Apex can be described as well as congruent and incongruent. Let's pay attention as to what is a pool or a broad apex.
We have this safety inspection coming up, so we're having to get all our files in order because part of that's an audit, and then checking all the machinery.
Pool or broad apex is a normal, typical apex. It describes a full range of expression. Now let's take a look into what is a blunted or a flat apex.
I lost my job at the hospital. They said I was drinking on the graveyard shift and a bunch of other stuff too.
Blunt or a flat apex is described as a dull expression. This is a negative symptoms of schizophrenia where there is a negative emotion and there is a decreased facial expression and gesture, and this resulted from a trauma or injury to the brain. Now, let's pay attention as to what is a congruent apex.
I mean, this dog that I've had for so long, I so much can happen, and I can just go home at the end of the day, and Lucky's always there.
In a congruent apex, which is shown by a clip where a lady lost her dog, it is just congruent that she is having a sad and lonely expression, which is congruent and appropriate with the feelings and what happened. Now, finally, let's take into a closer look as to what is an incongruent apex.
So like the other night I was driving home, and I just looking forward to being at home, and just
In a previously shown video of incongruent apex, the lady just lost a dog. And as she narrates her story, it is very incongruent that as she lost her dog, she has an elated or euphoric feeling, which is inappropriate for an emotion of losing a dog. Affect is described as full or broad, blunted or flat, and or congruent and incongruent.